Okay, let's dive right into this explainer. A huge welcome to all the PG residents joining us for this special, detailed review from the Anesthesia Learners Academy platform. Today, we're going to take the notoriously complex pre-anesthetic checkup and transform it into a crystal clear, highly effective clinical workflow. Look, this isn't just about ticking boxes on a chart. It's about mastering the framework that's going to help you conquer your exams and, much more importantly, keep your patients safe once you're in the OR. So let's get started.
Here is our agenda for today. 1. Goals of pre-anesthetic checkups. 2. Mastering the airway assessment. 3. Special cases and syndromes. 4. Cardiopulmonary functional capacity. And 5. ASA Physical Status Grading.
Section 1. Goals of pre-anesthetic checkups. The foundation. Listen, the crucial takeaway here is that a PAC is absolutely not just administrative paperwork, right? It's literally our primary clinical tool. We do this for 3 massive reasons: risk stratification, patient optimization, and formulating a totally customized anesthetic plan. If a patient rolls in with uncontrolled hypertension or diabetes, we don't just scribble that down. Our job is to optimize those comorbidities first. Only after we've optimized their physiological state do we formulate our final safe plan for anesthesia.
Section 2. Mastering the airway assessment, the physical barrier.
The Lemon score. This is our ultimate go-to structured mnemonic for anticipating a difficult intubation way before you even reach for a laryngoscope. You look externally, checking for trauma, a large tongue or a thick beard. You evaluate the 3-3-2 rule. You check their Malampati grade. You scan for obstructions like thyroid masses. And finally, you assess neck mobility to make absolutely sure they can reach that essential sniffing position.
Drilling down into the E of Lemon, we've got the 3-3-2 rule. You're literally using the patient's own fingers to measure out anatomical spaces. The first 3 is mouth opening. They should be able to fit 3 fingers, which is about 5 centimeters, right between their incisors. The second 3 is the Thyromental Distance, also known as Patil's test, which measures from the thyroid notch up to the chin. A normal distance there is 6.5 centimeters. If that distance is under 5 centimeters, it means there's just no anatomical space to displace the tongue. That is a massive red flag for laryngoscopy. And that final 2, that's the space between the hyoid bone and the chin.
And you're going to want to keep that thyromental distance in mind because it plugs right into another super high yield metric, the ratio of height to thyromental distance, or RHTMD. If we take the patient's height and divide it by that thyromental distance, we get a ratio. A value strictly greater than 23.5 is a highly sensitive and specific predictor of a difficult airway. So burn 23.5 into your brain. It's your magic cutoff number here.
Moving on, another fantastic bedside screening tool is the upper lip bite test, sometimes called the catch test. We literally just ask the patient to bite their upper lip with their lower incisors. What we're actually testing here is mandibular movement. It's such a simple trick, but it is highly effective. If they can protrude their jaw enough to bite above the vermilion line, that border between the red of the lip and the regular facial skin, their mandibular function is generally good to go.
Okay, the modified Malampati grading. This is a massive, high-yield topic for your exams and honestly, your daily practice. You've got to be able to visualize exactly how the oral structures disappear as the grade bumps up. In grade 1, you see everything: hard and soft palate, tonsillar pillars, the whole uvula. Grade 2, the tip of the uvula and the pillars vanish. Grade 3, you're only seeing the base of the uvula. And by grade 4, it's just the hard palate. Remember, the higher that grade, the harder your intubation is likely going to be.
Now let's quickly contrast Malampati with Cormack-Lehane so you never confuse them, because it's a super common trap. Malampati is your awake pre-op predictor. You're looking at the oral cavity while the patient is just sitting there in your clinic. Cormack-Lehane, on the other hand, is your intra-op reality. You assess it when the patient is asleep, and you are looking directly at the glottic opening and vocal cords right through your laryngoscope. Basically, one predicts the difficulty, the other confirms it.
Section 3. Special cases and syndromes. Identifying hidden traps.
So this brings us to a really critical clinical scenario. We see diabetic patients literally every single day, right? But why exactly is a long-standing diabetic patient such a major airway risk?
While the answer is stiff joint syndrome,
Chronic high glucose causes this glycosylated collagen to just build up in the joints, restricting mobility. And crucially, this affects the atlanto-occipital joint in the neck, which completely ruins your ability to put the patient in the sniffing position. We can actually screen for this right in the clinic. We use the prayer sign, where they try but fail to flatten their palms together, and the palm print sign, where ink on their hand will fail to print in the 4th and 5th interphalangeal areas. If you see these signs pop up positive, you better expect a stiff neck and a really tough intubation.
Now, for our pediatric patients, you've absolutely got to memorize these specific syndromes because their congenital anomalies are going to directly obstruct your laryngoscopic view. Pierre-Robin features a very small mandible. Down syndrome often presents with macroglossia, a giant tongue. Treacher-Collins restricts mouth opening due to severe facial anomalies. And Klippel-Feil syndrome limits neck joint mobility. Also, because these syndromes often travel in packs with other issues, you always need to screen these kids for congenital heart diseases or murmurs.
Section 4. Cardiopulmonary functional capacity. Assessing the internal engine.
To gauge this internal engine, we use metabolic equivalents, or METs. One MET is just the oxygen you consume at rest. In the clinic setting, we use normal daily activities as our benchmark. If your patient can easily climb 2 flights of stairs without stopping, they're operating at greater than 4 METs. That's great, but if they can't do it, they're operating at less than 4 METs. This is a huge indicator of poor cardiopulmonary reserve, and it immediately tells you this patient likely needs a much deeper cardiac evaluation before you proceed.
You know, you don't always need complex machines for this stuff. Sometimes your stethoscope and a watch are totally enough. You can use the forced expiratory time to instantly differentiate lung pathologies at the bedside. You just ask the patient to take a deep breath and forcefully exhale while you auscultate right over their trachea. A normal exhalation should take 3 to 5 seconds. If it's dragging on longer than 5 seconds, you're likely looking at an obstructive pathology like COPD. But if they expel all that air in less than 3 seconds, start thinking restrictive lung disease.
For formal cardiac risk stratification, we rely on the Lee Revised Cardiac Risk Index. This is brilliant because it's just so straightforward. You just sum up these 6 specific points. Is the surgery itself high risk, like thoracic or neurosurgery? Do they have a history of ischemic heart disease, congestive heart failure, or cerebrovascular disease like a stroke? And finally, check if they're on insulin for their diabetes, or if they have renal insufficiency with a serum creatinine over 2. Every single factor is exactly 1 point. The higher the score, the higher the likelihood of a major perioperative cardiac event. It's simple, it's rapid, and the whole surgical team understands it.
Section 5. ASA Physical Status Grading, the final verdict.
Notice how carefully ASA2 and ASA3 are divided here. It's all about functional limitation, guys. An ASA2 patient has mild systemic disease with absolutely no functional limits. So think of a well-controlled diabetic or a patient with a BMI of maybe 35. But an ASA3 patient has serious disease with functional limits. So morbid obesity, which is a BMI over 40, instantly bumps that patient up to an ASA3. ASA4 is a constant threat to life, 5 is a patient not expected to survive without the surgery, and 6 is an organ donor.
And of course, we also have the E suffix. We tag this onto the assigned grade to instantly communicate to the entire OR team that we're dealing with a high-stakes emergency. So if that otherwise totally healthy patient with well-controlled hypertension from the ASA2 category comes crashing in for a ruptured appendix, they immediately become an ASA2E. It just highlights the vastly increased risk profile of that acute emergency situation.
All right, now that you've got this structured framework burned into your memory, it's time to actually put it to the test. How are you going to apply this logic to keep your next high-risk patient completely safe on the table? Imagine you've got an ASA3E patient, functionally limited, crashing into the OR for an emergency. And you do your bedside screening, and bam, they reveal a positive palm print sign. You know their atlanto-occipital joint is stiff. You know they are metabolically compromised. So how does your plan change? Keep that in mind as you head into the wards today. Thanks so much for joining me on this explainer, and keep mastering those fundamentals.